Another engaging and thought-provoking conversation. At his inaugural lecture held at the Great Hall of the University of Ghana last week, Thursday, our guest for today raised several critical issues, including how the funding of health systems should not be left largely in the hands of donors due to the risk it poses with regards to sustainability, national ownership, and long-term planning. But at the heart of his lecture was an even deeper scientific question. When microbes speak and data we see appears inconsistent, are we witnessing falsehood or are we witnessing truth? This is a very loaded question which we'll be unpacking today. So we bring the conversation from the Great Hall to all of you here this morning on Radio Univers. We are more than happy that you tuned in. And once again, this is the Research and Innovation Agenda program on Radio Univers 105.7 FM. And we come your way every Wednesday from 9 a.m. to 10 a.m. And this is a platform for setting the agenda on the research, the impact of research conducted here at the University of Ghana. And it's a show through which we give voice to our faculty members and researchers who are working across disciplines. We will be interviewing people in the sciences, economics, development, food systems, and beyond, and to see how their research is impacting impacting us as human beings and making real life, solving real life challenges. So welcome once again to Research and Innovation Agenda. My name is Pascal Nsong, and I'll be doing this with my co-host.
Jane.
Yes, I think you have to. Do we hear? Yeah. Jane, your name is?
Jane.
Okay, Jane. Yes. So Jane is my co-host, and also remember that there's an interactive program. At some point, we will share a WhatsApp number on which you can share your comments or questions. Well, to welcome our guest to the show, I would like to invite Jane to give us a brief profile of our guest for this morning.
Thank you, Pascaline. Our guest today is Professor Nicholas Tete Kweku Jifa Dayie, a professor of medical microbiology at the University of Ghana Medical School. He's a leading researcher in clinical bacteriology and antimicrobial resistance, with advanced training from institutions including the University of Copenhagen and the London School of Hygiene and Tropical Medicine. His research focuses on strengthening AMR surveillance systems, laboratory quality, and the generation of reliable data to guide public health decision-making. His inaugural lecture titled, When Microbes Speak and Data Appear Inconsistent, Are We Witnessing Falsehood or Truth?, challenges us to rethink how we interpret scientific data and build systems that truly reflect reality. Prof, you are welcome to the show.
Many, many thanks, Madam Pascaline and Jane.
And congratulations on the successful delivery of your inaugural lecture last week, Thursday.
We give thanks to God.
Yes.
Thank you.
Yes. So, Prof, before we delve into the topic, I would like you to tell us a bit about your journey into medical microbiology.
It's a very interesting journey, and I would say it's between God and opportunity. So I began my primary school at Anglo State School at Keta, where I was so much interested in agriculture. So at the final year, I chose Bishop Herman Secondary School and wanted to read agriculture, although my science teacher says, Nick, you are very good in pure science, so why don't you pick that up? I said, no, I love agriculture. So fortunately, I got into the agriculture program at Bishop Herman Secondary School between 1994 and 1996. Right. Though during my subjects, elective subjects were general agriculture, agriculture, economics and extension, and horticulture. I didn't read physics, chemistry, mathematics, and biology. Okay. So then at the final year, I asked the head of department of the school that, what is my future? Or those of us that are reading this program, what would be our future? He said, the only place you end up would be Nyankpala Agriculture Training College.
Wow.
I was a little bit disturbed because I have a lot of potential I wanted to explore. So fortunately for us, we had a team of old students from University of Ghana who came to us and spoke to us. So I asked, is it possible that I could become a biochemist or a microbiologist or a toxicologist. Then they asked me, what program are you reading? I said agriculture. What were your electives? I mentioned. They were really in doubt as to whether I could venture into any of these fields. But deep within me, I knew I love agriculture, but I do not want to be there permanently. So we wrote the final exams and I qualified. And at that time, University of Ghana says they weren't going to take people like us who didn't do pure physics, chemistry, biology to enter into the agri program. I have a view that the curriculum was actually made for us to go into farming directly at the time. So University of Ghana says they will not pick us. University of Science and Technology, Kwame Nkrumah University of Science and Technology says, no, we are not their candidates. The only universities at the time that were willing to pick us up were University for Development Studies at the North and then University of Cape Coast. But then, of course, first year in the university, you are given opportunity to read physics, chemistry, biology, additional mathematics, not in a segregated class, but you were actually put in the midst of those who read physics, chemistry, biology at the secondary school. So that was what happened. First year, I was introduced to physics, chemistry, biology, and additional mathematics. And that was great for me. Then the next year, which was level 200, and you have to make a certain grade point to be able to proceed with your agriculture program. So the next year, I thought we would go straight into the agriculture I know. It was rather biochemistry.
That was at the university level.
At the university level. Biochemistry, soil physics, soil chemistry, soil microbiology, animal health, and the like. So I then understood why University of Ghana was not interested in our category or student. But I thank God that University of Cape Coast gave us an opportunity to build the foundation that would be necessary for our future. In the course of the program, I met a man, a very powerful teacher. Teachers are great people, and we should respect and honor them. This teacher's teaching inspired me to have an understanding of what microbes are, because he taught us veterinary microbiology. So I became so fascinated about the invisible world, and I love those invisible creatures. And he was interested in giving me additional tuition, even when outside classes. So that is how come I was introduced to microbes, and I loved it from that day onwards. So that was the beginning of my transition from agriculture to basic microbiology. But then after first degree, I applied to University of Ghana now because I wanted to come to UG. And when I applied to read agriculture.
That was for your master's?
For my master's. Interestingly, I was waiting for my admission or a call to come for an interview. But instead of coming from School of Agriculture, the letter rather came from University of Ghana Medical School, Department of Medical Microbiology. And I was really shocked at the turn of events. And that was the beginning of a great change in my academic pathway. So I came for the interview. We were 26 in number. They took 3 of us, and 2 of them were actually already working within University of Ghana. So I was the only external person taken. And that was the beginning of my understanding of medical microbiology. And ever since, I've been in the field.
That's interesting.
That's an interesting journey. So, Prof, how was the transition from agriculture to medical microbiology?
I should say that, we are just pencils in the hand of the Creator. If somebody is painting something until you enter his mind, you wouldn't know the final picture. God was just painting a picture of one health expert in 30 years to come. At that time, reading agriculture, I thought that was it, but he had a different mindset altogether. So UCC gave me that foundation in pure science that gave me the opportunity to climb smoothly. And when I got to the medical school, that was a little bit tough at the beginning. But then when people are sleeping, enjoying themselves because they have very good foundation, I have to do more reading. And then go into laboratories to make a lot of practicals, gain skills that will make me very relevant in my field. And then maybe let me complete the story for you. Then after the master's, I applied to be a teaching assistant But then later I was called rather that the only available position is assistant lecturer. So I finished in the year 2006 and I got into University of Ghana as a faculty in the same 2006, and I was told when my MPhil is passed, then I could be upgraded to that of a lecturer. So within 3 months, my thesis was passed, and I was upgraded to that of a lecturer. So I've been teaching medical microbiology to medical students and helping in a lot of research work. Then one day, because at the interview when I was being taken, they asked me, "What do you want to do in the next 6 years?" I said, I really wanted to do a PhD. So yes, so when I came in three years after, I wrote to 350 schools looking for opportunity to do a PhD.
I mean, this is very important for young people because sometimes I think that young people give up too easily. 350 times.
Yes.
Wow.
I wrote that, and I want to thank those who wrote the recommendations for
I can
me, because
imagine,
I was
yeah.
just because of what they did for me. I also extend such kind of kindness to students who approach me, write recommendation for me. So 350. All I get is, "Oh, good CV. Can you tweak it this way? Do it this way. Oh, I wish I could supervise you." And all the 350, I didn't get anything but correcting my CVs for me. And that was great. Then one day I asked a departmental meeting that I want to do the PhD here while still working. They said no. I said, I will be sacked from the university if I don't get a PhD done. They said, it doesn't matter. So I called my wife and said, we need to pray. After prayer, 3 days after, I received a call from University of Copenhagen asking me to nominate one person for a PhD. So I called back and said, I'm not the head of department. Secondly, I don't have a PhD myself, but can I nominate myself? The professor said, why not? So I nominated myself. That got me into Copenhagen. But before I got to Copenhagen, he said, Nick, just wait a minute. I have a grant coming to Ghana on antibiotic drug use monitoring and evaluation of resistance. Are you interested in participating in this? I said, why not? So together, we worked together to develop the proposal, engaging all the relevant stakeholders. And finally, we got about 1.5 million US dollars. That translates to about 9.8 Danish crowns. That money trained 6 PhDs from Ghana, 14 MPhils in medical microbiology.
At the time.
At a time.
Right.
And that took me to University of Copenhagen School of Global Health. And I was fortunate to be there and to be mentored by great minds that shaped my perspective in molecular bacteriology and infection.
Well, Prof, thank you. I mean, this journey you've walked us is very important because sometimes, especially if we have some of our students listening in, people think that what they are studying now ties them or puts them in a certain narrow tunnel and that there's no way to move, onto other things. So I think that this is an inspiring journey that if we have young people listening, they know that you have to seek or find out what the possibilities are in every subject that you are studying. Is there a possibility to move into another branch of that subject, just in case you don't see your way ahead and all of that. But I want us to come now to the lecture itself. The lecture itself, it's a lot of scientific words and want to unpack those words. So we'll start first of all with, to an ordinary person, what is microbes?
Okay, in our environment, there are 2 types of living things. We have those that are big enough for the naked eye to see, like you and I,
Right.
like trees, like shrubs, like big animals. We call those ones macroorganisms. Then we also have another group of living things that are too small for the naked eye to see, except with the help of a microscope.
Right.
Those are the ones we call microbes or microorganisms. Now, the field of science that deals with microbes, we call that field of science microbiology. And now the people who study microbes or microorganisms, we call them microbiologists. So microbes is a general term, and it includes bacteria, viruses, parasites, and fungi. But I am a bacteriologist because I study bacteria. And even bacteria, we have different types. We have bacteria that are commensals. That is, they live in harmony with our cells. They help us in digestion. They also help us to metabolize. They help us in food production. They help us to produce vitamins. And of course, if one day you decide to die, they also reduce your flesh to dust.
Okay.
That is the commensals. Then we have another group. We call them pathogens, meaning they produce toxins that cause various pathologies in the body or that cause disease. So disease-causing bacteria are pathogens. Disease-causing viruses are also pathogens. Disease-causing fungi are also pathogens. But I am a bacteriologist, and therefore I'll concern myself with bacteria. And the entire lecture is about disease-causing bacteria.
Right. Okay. So I wanted us also, you keep talking, or we kept hearing antimicrobial resistance. What is this all about?
So when you are infected with a bacteria, it means it will lead to disease. When you get the disease, you have to be treated with an antibacterial agent, which we will call antibiotics. Or we may use the general term antimicrobial agents. So over time, the first antibiotics was penicillin, discovered by Alexander Fleming. And I'm privileged to be an Alexander Fleming Fellow from the London School. And the organisms have thought about the ammunition we found against them, which is the antibacterials or the antibiotics. So at a point in time, they became, or they evolved. That is, they changed their structures. In medical or in a scientific term, we'll call it they mutated. They changed their structures so that they can become insensitive to the effect of the antibacterials that we are using to treat them. Now, some of the antibacterials are bacteriostatic. That is, they only retard the growth of the bacteria. They don't kill it. They retard it so that your own body will mount an ammunition against them. Your immune
What we
system.
call resistance.
Exactly.
Is that the layperson's?
No, your
Defense?
the defense mechanism of the body.
Right.
So the antibacterial, some are bacteriostatic. So they only restrict the growth of the organism so that they don't multiply. Then your body mounts a defense against them and kill them. The second group, we call them bactericidal. And cidal simply means kill. And so the bactericidal antibacterial, they kill the organisms, the bacteria, completely. So when they are killed, then there's no disease anymore. You get healed as a result. So the organisms become insensitive to the antibacterials, and we call that insensitivity, we call it antibiotic resistance or antimicrobial resistance.
In fact, so you just mentioned what my next question would be. Because we keep hearing antimicrobial resistance, and what is it really? What is antimicrobial in layperson's terms? We want to understand it. So someone is listening and doesn't have any science background. Yes.
So it is not the human being that becomes resistant to the antibiotics. It is the bacteria that is causing the disease that become insensitive to the effects of the antibacterial agent or the antibiotics. So if they become insensitive to it, it means that the antibiotics can no longer kill them or retard their growth. They do that by two means. One, some of them have inherent capabilities of becoming resistant to certain antibiotics naturally. The second one is that they change their structures. As a result of that, the antibiotics cannot bind to the specific targets and therefore kill them. The third opportunity is that they also acquire resistant genes from their environment. As a result, they become resistant to the drug. So it's not the host, the human being, that is resistant to the antibiotics, but rather it is the pathogen that evolve and become resistant to the antibiotics.
I think this is very important because most of the time we think that it is your body that has developed that resistance to the antibiotic. Now, talking about antimicrobial resistance still, how serious is this, looking at the world generally and then Ghana specifically?
It's a huge problem. And I've developed so much interest in this area of science because, one, it is not just a laboratory problem. It is a patient care problem. It is a public health problem. It is a national development problem. Now, globally, in 2019 alone, 1.27 million people across the world died as a result of infections that are caused by drug-resistant bacteria.
1.27 million
died.
That's quite,
In the same year, that is attributable death directly related to them. Then the same year, about 5 million people's deaths were associated with infections caused by drug-resistant bacteria. Now, there is a difference between attributable death and associated death. The difference is this. With attributable death, it means that the death is as a result of a direct relationship between the pathogen and the death of the patient. But associated death means that there are other underlying disease conditions, like, for instance, hypertension, diabetes, maybe a person is on cancer treatment, and so forth. Their immune system are already low. But then, of course, when they died, they found that certain organisms were also associated with their death. So with the attributable death, if we provide an antibiotics that works and we kill or retard the growth of the organism, the patient wouldn't die. That is attributable death. But with associated death, when you even provide the antibiotics and kill or retard the growth of the organism, the patient may still die because of the underlying disease conditions. So these are the two things. So 1.27 million people died in 2019 alone. That is attributable death. And associated death was about 5 million people who died. And then it's been estimated or projected that if we go along this trajectory without the containment of antimicrobial resistance, by 2050, 10 million people will die every year. And the situation is so grave in sub-Saharan Africa. We bear the brunt of this AMR problem. 10 million people every year will be wiped out by 2050. So no matter all the development that are going in Ghana, if we don't focus on this and contain it, we are in trouble. Now, that is the global burden of AMR. If you come to Ghana, the issue is even interesting. In Ghana, in 2019 alone, 5,900 deaths were directly attributable to AMR. 5,900 died directly due to AMR in 2019. And 25,300 deaths were associated with AMR in Ghana. And it's been ranked. Ghana has been ranked out of 204 countries. Ghana was ranked the 35th in 2021 for deaths linked to AMR.
In the African region, sub-Saharan Africa, or the worldwide?
Worldwide.
Okay.
That's quite
35th.
concerning.
And that is quite concerning. And we need to do something about this. Now, these deaths, how do they show themselves in the various disease conditions we have in Ghana? Majority, they are just a few of them. We have bloodstream infections. We have lower respiratory tract. Bloodstream infection simply means the blood of the patient is infected with bacteria.
Okay.
That's the topmost one, followed by lower respiratory tract infections, like infections caused by Streptococcus pneumoniae, tuberculosis, and the rest. in the lower respiratory tract. The lungs are infected. The third one, meningitis, diarrhea disease. These are few. These are the few ones that we know that are causing most of the disease syndromes as a result of AMR. And only few pathogens are also associated with this.
Are you able to tell with this data whether children are most affected, men, women? How do you have details on that?
Yes, I have details on that. Mostly they are the very young people and then also the very elderly.
Right.
So, Prof, how do people get affected? As in, what lifestyle or behaviors,
So there are different pathogens and different mechanisms of transmission. We have those that are airborne, those that you need to touch, and those that you need to have a cut for them to enter, and those that are transmitted via food and water.
Oh, okay.
So that was the food and water one would be the bacterial, the diarrheal diseases that you mentioned.
And then the lower respiratory tract infections would be
Right.
those that are transmitted by air.
The airborne, right. Okay. Right.
Yeah, so, apart from death and maybe chronic illnesses associated with the resistance, what other areas of our everyday life is affected by?
So in 2017 alone, AMR has an economic cost. In 2017, the world lost $300 billion US. We lost that. And then in 2050, it is projected that the world will lose $100 trillion US if nothing is done about AMR. That's the economic cost. Now, let me bring it home. If you get an infection caused by antimicrobial resistant bacteria, what it means is that you have longer hospital stay. You will not get cured quickly. Longer hospital stay. And if you are the breadwinner of your home, it means that you lost man hours. You wouldn't be able to go to work. And the people taking care of you would also not go to work. They will stay with you. Then if you cost those individual losses of time and working, and you multiply it by the total number of people in Ghana, that translates to a reduction in our GDP because people will not be able to go to work. So AMR can also lead to poverty.
Absolutely.
It's interesting because we hardly we hardly think of that, and reason why it must concern each and every person. Yes. And I like that at the lecture you advocated strongly for some of these things. Well, coming back to your topic, you talked about truth versus falsehood in AMR data. Yeah. What does this mean?
It's so philosophical.
Yes,
Let me
exactly.
put it that way. Okay, truth simply means the genuine microbial reality or the genuine characteristics of the organism with nothing added to it. So we want to capture exactly what the organism is made of.
So in simple terms, if I fall sick and I go to the hospital and maybe my blood is drawn,
yes,
and it goes to the lab, what we will call the lab,
yes,
the action that takes place in the course of trying to identify what exactly is making me feel sick.
Yes.
Okay.
So we want to capture that organism that is making you feel sick. But that is the truth. That is how I define truth. So data is not all data is truth. Some data appear to be truth, but they may not be truth.
Can you break that down for us?
Yes, so I will do that.
Yes.
So let me define the falsehood, then I'll come to this. Now, falsehood in this lecture does not mean dishonesty on the part of the laboratory worker.
Okay.
Far from that.
Right.
Falsehood doesn't mean the laboratory worker is falsifying data to present to the clinician or fabricating data to present to the clinician. Falsehood simply means in this lecture a distortion in the process of data production that make the data to be inaccurate. A distortion in the system of data production that make the data inaccurate, so that the etiological agent that made you sick, for which reason you went to the hospital, if that organism is not properly identified, that improperly identified organism will be presented as data to the clinician. And based on that, he would treat you.
So again, in simple terms, this also means that, let's say I go to the hospital, maybe not feeling well, my blood is drawn, and it's seen that I have some bacterial infection of a certain kind. But meanwhile, what is presented is not that particular kind of infection, but another infection. That's quite scary then.
Very scary.
Yes.
And it's so dangerous. And those are the things that we want to solve through quality assurance in data generation with respect to antibacterial agents and the bacteria in the lab.
Right.
So, Prof, from what you said earlier, it means that it's not intentional. It's just the way the data is handled.
It's not intentional. It is the system that they are operating with that is making the data to be inaccurate.
Which makes all of us victims of the system.
Of course.
Now let's look at that system you talk about. What is it?
Well, when microbes, they speak. When they speak, what they spoke will make you shiver, will have symptoms. Okay? So you go to the hospital. The doctor takes the sample, or the laboratory worker takes the sample. It goes through a process. After the process, they identify an organism or a bacteria. After the identification, they are supposed to produce another data we call antibiotic susceptibility testing data.
Okay.
That test is what determines which antibiotics the doctor should select to treat you. They are not supposed to just prescribe drugs for you to take. They are to prescribe drugs based on the antibiotic susceptibility test results. That test would unveil to the doctor that, okay, this organism is resistant to antibiotics A, B, C, and D. Therefore, don't prescribe them. This organism is susceptible to antibiotics D, so and so. Those are the ones you should prescribe. In the absence of the antibiotic susceptibility test, doctors prescribed empirically.
So it means that you could be given a medication to treat a certain bacterial infection, and it's not working because the particular organism that is causing that illness has not been found out.
Exactly.
Or
they found the organism, but in the process of producing the antibiotic susceptibility test result, they made mistakes in the testing, and therefore the outcome of that test does not give the doctor the right information to prescribe the right antibiotics for you.
Then that's very scary.
So, in simple terms, it means that the drug prescribed may not work against the particular bacteria you have.
Exactly.
Okay.
Well, it's serious
and
issues.
Bacteria multiplies every 30 seconds. So that mistake of not getting it right the first time puts you in danger because the organism will continue to multiply and to lead to complications and can result in death.
Well, serious issues here on Radio Univers 105.7 FM. This morning we are speaking to Professor Dayie. He delivered his inaugural lecture last week, Thursday, at the Great Hall of the University of Ghana. He had quite an interesting topics on microbes and antimicrobial resistance, and today we are unpacking the issues. He's making us understand that sometimes when you go for a laboratory test, it could be that because of the analysis that is not properly done at the lab, you could be given medication that might not really. So that's why it's important. That might not really help in your case, because sometimes you realize that they tell you that if the medication is not working, go back to the hospital. Go back to the hospital, maybe a second test and all of that. But this issue still dwelling on the system, the testing system. What are some of the reasons why we have the falsehoods that we have?
Okay. There are several. If you take the testing system, we divide them into three parts. The path of workflow. We have the pre-test, we have the test, and we have the post-test. The entire process is divided into three: pre-test, test, and post-test. The pre-test is characterized by first identifying the right test to select. The second one is sample collection. The third one is transportation of the sample from maybe the ward to the lab. Now, the pre-test environment is not only the laboratory worker who operate in that environment. The clinician is also part. Now, as part of the work of the laboratory worker, for it to be very effective, the clinician must give a clinical diagnosis of the patients. At least tell the laboratory worker, this is what I envision that is happening to this patient. That should be documented on the laboratory request form before the sample comes to the laboratory worker. Based on that information, because they are not magicians, they need to know what the doctor thought about the patient. Then based on that, select the right test to be performed, the right reagents to be assembled, the right equipment to be assembled. Now, doctors sometimes also take the samples themselves and then send to the lab. Now, in sample taking, or either doctor or the laboratory worker taking the samples, if the samples are not taken based on standard operating procedure, an error is introduced at the beginning, no matter what you do in the testing phase, it will never correct anomaly. So if the pre-testing phase is flawed, then forget about the testing and the post-test phase that gives the result to the doctor. So we have seen a lot. For instance, in performing the antibiotic susceptibility, I just want to give two examples. You need to prepare what we call media. Media is the food for the bacteria to grow on. Now, when you are preparing that media, you have to pour into what we call a petri dish. Per the standard, it has to be, if it is 90 millimeter petri dish, then the quantity of medium you pour in would have to be 4 millimeters deep. The depth should be 4 millimeters. Anything short of that will affect the result. Now, when you go, our laboratories, they don't have a measuring rod that can give them that 4 millimeters deep. Until recently, the Fleming fan bought it for them.
I see.
So these are laboratories generally or in specific hospitals?
All.
Also in Ghana,
we touched on most of them.
That reminds me of how we even cook here, adding the salt and tasting, it seems to be the same.
So
wow.
They will tell you they have the experience. But quality assurance, if it is 4 millimeters, it must be exactly 4 millimeters. And then there is another one called the quantity of bacteria that you put on the medium has been tested to agree with a particular measurement that should go with a particular antibiotic concentration. We call that inoculum size. Inoculum size is the quantum of bacteria that you introduce to a particular antibiotics in the testing. So we want your inoculum size to be equivalent to what we call 0.5 McFarland standard. Please understand that for me. But in doing that, you need an instrument called a nephelometer or a turbidometer that determines the density, how thick or light the inoculum should be. You know what they do? Until recently, the Fleming fan helped. They do what we call inometer. That was the first time I heard it when we went for the tour. Instead of using the equipment, they use their eyes to see.
Wow.
And so what you see with your eye is different from what another person sees with their eye. So there is no way that result that will come out of that test will be credible. Now, it's not their fault, because that piece of equipment that they need to do the job, when I checked on it 2 weeks ago, is 83,000 Ghana cedis. One, it's a small piece of equipment.
Wow.
How many of the laboratories do have the means to do this? Until recently, Fleming Fan bought for them. They were not having it. So you see ways of introducing variability in the testing result, which is not just numbers. mistakes they do, it's not just numbers. It's about human life. It's about human life.
That's interesting. But I think you've mentioned the pre-test stage. I think you've done the testing stage as well. Have you touched it briefly? You haven't touched. Okay, so you're coming there. Yes. So let's hear about the testing. Yeah.
Assuming there was no problem with the pre-testing phase, everything was done based on standards. In the testing phase, when you prepare the food for the bacteria, you have to put it inside what we call the incubator for 24 hours in order to test whether this food is contaminated with other organisms or not. If after 24 hours there's no other growth of bacteria on it, it means that food is good even for the bacteria.
Okay.
Now the second one is that you also need to do what we call growth promotion test. That is, we have control strains, standardized bacteria that you have to grow on few of the food that you've prepared and incubate and see whether the food you've prepared will be able to grow the bacteria or not. That particular one is hardly done, but the first one is done, which is the sterility test. That is done, but the growth promotion test is not done for some of the laboratories. Because if you don't test whether that food you've produced can grow the organism, eventually you just come and tell the doctor, no bacteria growth. We didn't see anything. Meanwhile, it may be because the food you prepared, you didn't prepare it well. So it's not able to support the growth of the organism in the sample. Then the next one is this. Every batch of antibiotic susceptibility tests that you do, you have to set up controls. The controls will determine whether the test you are doing is correct or not. And most laboratories do not have the control strains to be able to do that. Until recently, the Fleming Fund provided it. So that is about the testing phase. And in the testing phase also, we need calipers to measure the impact of the antibiotics on the bacterium. When there is an impact, there is a sphere of no bacteria around the antibiotic sticks. We use ruler to measure, but calipers do a better job. Until recently, before that was also provided by the Fleming Fund. And Fleming Fund supported only 20 laboratories.
Wow.
We'll come to that because the diagnostic capacity is important.
Across the country,
Across
20.
the country. No, they supported 20 out of the 93 that have. We'll come to that if you.
Right. Wow, this is interesting. The program is a research and innovation agenda on Radio Univers 105.7 FM. We are speaking to Professor Nicholas Dayie, who is a medical microbiologist with the University of Ghana Medical School. He delivered his inaugural lecture last week, Thursday, at the Great Hall, and we are bringing the conversation here so that we can, a wider audience can hear him out. If you want to join the conversation, you can send us a message on 059 519 4218. The number again is 059 519 4218. 059 519 4218 is the WhatsApp line you can join the conversation on. Well, Prof, during your lecture, you spoke about surveillance. What is the whole process of surveillance? How is it like in antimicrobial resistance?
Okay. Surveillance refers to a systematic collection of data on antibiotic resistance, analysis of the data, interpretation of the data, and the usage of that data to shape policy on antimicrobial resistance, to help review the standard treatment guideline of Ghana, and also to assist antibiotic stewardship programs. The surveillance is not just data collection. if eventually you collected the data, it does not lead to action. That is not surveillance. Surveillance must always lead to action. It must affect policy.
Yeah. So, okay. Yeah. Prof, you go ahead.
Okay. Now, surveillance is antibiotic resistance surveillance data is only reliable if it is based on the diagnostics capacity of the country. So if diagnostics is wrong, surveillance data will be poor. And poor surveillance data will lead to poor national decisions. Remember, surveillance also help in the allocation of scarce resources. And the last time I checked, the law of causing financial loss to the country has not been revoked. So if your action leads to a surveillance data that led to misallocation of scarce resources, then I want to invite the lawyers in.
In talking about the surveillance aspect, you've taken us back to diagnostics. I just want to find out, in training, I know that the Department of Medical Microbiology is suited in the University of Ghana Medical School. And I think is there another one in the Allied?
Exactly.
Yes, there's another one in the Allied. And I can understand why. I used to wonder why there were two departments with the same names, in different, but I understand now, because for those being trained to be medical laboratory technicians, they need to know these things. And also for those being trained in the medical field also, they also need, because you've told us that the clinicians are as important as the lab. How robust is this training?
For the laboratory personnel, it's very robust.
Okay.
For the clinicians, for their first degree, that's the MBCHP, the only time they have microbiology taught them is level 300. But they come back to do their fellowship. They call it the laboratory physicians. During that fellowship, they have a thorough understanding of the field.
Right. Yeah. Prof, let me take you back a bit. During your lecture, you mentioned genomic surveillance, and that has to be with how you mentioned genomic surveillance during your lecture. So I want to know, how adaptable are these bacteria? It seems as if they evolved to stay ahead of us. Yes.
So genomics is actually the study of the genome of a bacterium or even human beings. A genome refers to the total gene load of an organism. That means all your genetics that make you up is your genome.
Okay.
Now we have a tool that gives us access into the genome of a bacterium. We're in the field of molecular biology. Now, when you get into the genome of the organism, it means you are looking at the blueprint of that organism. You see everything. You see the genes that will make them to be resistant to particular antibiotics. The gene that will make them to be very virulent. That is when they cause disease, it will be very severe. All those characteristics of the organism can be assessed based on the genomic data.
Okay.
So the genomics actually gives you a foresight or an insight into the secret chambers of the bacterium. Way ahead, that knowledge is supposed to help infection prevention control officers or the department in every hospital. If they have access to that, then they can be proactive instead of reactionary. Unfortunately, very few institutions in Ghana have access to genomic data production. Fortunately for us, we have the Noguchi Memorial Institute for Medical Research. We also have the WACME also there that gives us this. But of course, if we are interested in getting to know ahead of the microbes, genomics is the way to go.
But as we gradually draw to a close, I wanted you to touch on misuse of antibiotics because some people will just probably walk. I'm not too sure if all antibiotics are off the counter. for instance, especially in our country where we don't have a lot of regulations regarding walking to the pharmacy and buying medications. I want you to touch on it so our listeners will know how very serious this is.
Okay. There are two things that drive antimicrobial resistance. The first one is, we call them factors that influence selection pressure. And the second one is the presence of what we call high-risk clones. I will explain this.
Okay.
Now, let me deal with the first leg.
Right.
Factors that influence selection pressure. Number one is abuse of antibiotics. When you take in, if you have cold, for instance, most of the cold is as a result of a virus. And antibiotics don't kill viruses. So if you have a cold, you don't need to go and take antibiotics. Okay. So abuse of the drug will lead to what we call a selection pressure. That will kill susceptible bacteria. But resistant bacteria, they have to survive. So they evolve and adapt, and they become resistant to the drug. And being resistant to the drug, they can also pass on the resistant genes to other organisms in the environment. So that is why we don't need to misuse antibiotics. You don't have to self-medicate, which is the main thing of most Ghanaians. And I can understand them. Why do you have to go to hospital and stay for hours before you are seen to? It is not the doctor's problem because of the doctor-patient ratio issue. So people would prefer to treat themselves based on what they knew in the past, that perhaps I've gone to the hospital and the doctor prescribed this drug for me. Now I'm having the same symptoms. So I believe it's the same organism. So I will go and buy the drugs myself. Sometimes they may not buy the full dosage also. They may only buy just a few because they don't have the money to buy all. So that incomplete taking of antibiotics also drives selection pressure. But another important thing is this. You see, in antibiotic stewardship, it is said, use antibiotics only when needed. How do you know when it is needed? You need to go to the lab for them to identify the etiological agent. Number two, they said, use the right antibiotics for the right pathogen. How do you get that knowledge? Only through diagnostics, isn't it? The third arm is this. The doctor is supposed to give the right dosage. How do you give the right dosage? Between 2015 and 2020, there is a publication from the ADME project, that is Antibiotic Drug Use Monitoring Evaluation of Resistance. In that project, a colleague of mine analyzed antibiotics that were being sold in Ghana in both authorized sales point and unauthorized sales point.
Unauthorized,
He collected 348 antibiotics from both sides. And when he did the drug quality analysis in Copenhagen, he came to the conclusion that 66.4% of the antibiotics do not have active pharmaceutical ingredient up to 50%. So how would the doctor, assuming the doctor is prescribing and those are the drugs in the system, how would he determine the right dosage? So you may be receiving drugs, antibiotics given to you based on the label. But what is on the label is not what is in the content. So how do you get the right dosage?
It's a very complicated issue. I wish we had more time. Prof, we had a question coming in. I'm not sure how this is very related to what we are discussing, but the person asked the question. This is from Frank from Pent Hostel. He asked the question about hepatitis B. He wants to know if it's viral or bacterial.
It's viral.
It's viral. Okay. And then he wants to know, I don't know if at this stage you can provide any assistance. What is the risk of contracting hepatitis B? Even though we are talking about
body fluids.
Okay.
Body fluids, mostly through sex.
Yeah.
Or if you go to cut your hair
and
you have not been vaccinated and there's a cut, you get infected.
Right. Okay.
And I'll recommend that he should just go to the hospital
Exactly.
and get tested.
They're tested, yes. In
Once
fact, we are
you-
all supposed to be testing for hepatitis, right?
Yeah.
Yes, yes.
Get
right,
tested. Don't be
right.
afraid.
Yeah.
Because if they get to know early, there is treatment.
Right,
Yeah.
right. So thank you very much, Prof. We've come to the end of this week's edition of Research and Innovation Agenda. We want to thank you so much for making time. There's so much we could have discussed, but time is not our friend this morning. So we'll have to end here. But I would like to move to Jane to do a few acknowledgements before we leave.
Right. So we'd like to take a moment to appreciate the people who have supported the Research and Innovation Agenda program. First, our sincere appreciation goes to Professor Felix Ankuma Asante, Pro Vice Chancellor for the Research, Innovation and Development. Pro Vice Chancellor for Research, Innovation and Development for his leadership and commitment to advancing research. We also acknowledge Professor David Oduahin, Director of the Research and Innovation Directorate, and Professor Nancy Kwashi, Deputy Director, for their support. Our thanks as well to Mrs. Cynthia Edu, Deputy Registrar for Research, Innovation and Development, and Dr. Elizia Amiabonya, Director of the Public Affairs Directorate. We appreciate the efforts of the Publication, Dissemination and Translation Unit of RID, as well as the team at the Public Affairs Directorate for their role in bringing this program to life. And finally, special thanks to the producer of the show, Alexander Kukwose-Bedu, for making today's broadcast possible. And then we would also like to thank Benedicta, who assisted Alexander Osebedu.
Well, so we've come to the end of this. But maybe we just have a minute to put in a final word before we leave.
All right.
Yes.
So antimicrobial resistance is real. It is growing and affects all of us. But we can respond effectively if we build strong systems. We must ensure that antibiotics are used responsibly, laboratories produce reliable data, surveillance systems are strengthened, and policies are guided by truth, not assumption. Because at the end of the day, when microbes speak, our systems must hear clearly. First for the patient, second for the nation, and third for the global community. Thank you for hosting me.
Thank you very much, Prof. You just heard the voice of Professor Nicholas Tete Kwaku Dayie. He is with the University of Ghana Medical School, specifically with the Department of Medical Microbiology. Last week, he delivered his inaugural lecture on the topic, When Microbes Speak and Data Appear Inconsistent, Are We Witnessing Falsehood or Truth? And Prof also doubles up as the International Programs Coordinator for the College of Health Sciences. Thank you for making time on today's edition of Research and Innovation Agenda. We also want to acknowledge the General Manager and Station Officer of Radio Univers and the entire technical team that made it possible for us to bring you today's program. We want to invite you to join us again next week for another conversation on Research and Innovation Agenda. And thank you for joining in. My name is Pascaline Songsori, and this program was co-hosted by
Jane Opon.
Yes. Have a lovely Wednesday.